Hello, everyone, and welcome to the second webinar in our two-part series. Today, we're continuing our conversation on the opioid crisis and its impact on individuals experiencing homelessness who may be eligible for Social Security benefits. My name is Pam Hine, Senior Project Associate with the SOAR Technical Assistance Center, and I will be your moderator today. A quick disclaimer before we start. The training is supported by the Substance Abuse and Mental Health Services Administration and the U.S. Department of Health and Human Services. The content of this presentation do not necessarily reflect the views or policies of SAMHSA or DHHS. The training should not be considered substitutes for individualized care and treatment decisions. Before we begin, I'd like to introduce to you Robert Griss, SOAR Project Officer, who will provide today's welcome. Bobby? To provide today's welcome, you may be muted. Bobby may be having trouble with his phone, so we'll get back to
Can you hear me now?
Yes, I can, Robert.
So sorry about that,
That's okay.
everyone. But Pam, I appreciate it. And thank you all for joining us today. On behalf of SAMHSA and the Substance Abuse Administration, the Substance Abuse and Mental Health Services Administration, and the Programs Branch of the Mental Health Services, I would like to welcome you to Part 2 of the SSDI Outreach, Access, and Recovery SOAR webinar called Understanding Opioids and Other Drugs, How it Impacts SOAR Applications. States and communities increase access to Social Security ability benefits for eligible adults who are experiencing or at risk of homelessness and have a mental illness, medical impairment, or co-occurring substance use disorder. Today's webinar will focus on opioid crises in the United States and the case of people with disabilities who are experiencing or at risk of homelessness. We know that the opioid crisis has significantly impacted the vulnerable population. That's part one of this webinar. To further address the crises, the U.S. Department of Health and Human Services has awarded an additional $144.1 million in grants to and treat opioid addiction, which are administered by SAMHSA. SAMHSA's website at www.samhsa.gov to access more tools and resources on this topic. So I will turn the webinar over to Pam, who will be reading today.
Thank you so much, Bobby. We appreciate your support for this webinar series. Just a couple more housekeeping items before we begin. As a reminder, your lines will be muted throughout the entire webinar. This webinar is being recorded and will be available for download on the SOAR website in about a week. You may download the presentation slides now by going to the top of your screen. To the left, click File, then Save and Document to download materials, or you can also go to the SOAR website to download materials at soarworks.prainc.com. Scroll down to Webinar, click, and find today's topic. At the conclusion of the webinar, you will immediately be connected to a brief evaluation which we kindly ask you to complete. And finally, we will save all questions and comments until the end of the presentations, at which time we will review instructions for posing questions to the panelists via the chat function. So it is our intention that by the end of this webinar, you will have a better understanding of opioid use and misuse amongst people experiencing homelessness with co-occurring disorders and have a better understanding of the clinical consequences of addiction to opioids and the differences between prescribed treatment and addiction. You'll learn more about the opioid crisis in Portland, Oregon, treatment options and supportive services available through the Central City Concern agencies. And again, increasing your knowledge of the signs of opioid addiction and related treatments and services to better serve SOAR applicants. And again, this week we will be having Social Security policy experts on the line who will discuss SSA policy on how they evaluate pain, substance use disorders, and co-occurring disorders. So as Bobby mentioned in his welcome, to reach these objectives, we will begin this afternoon with a presentation from Dr. Andrew Mendenhall, who is the Senior Medical Director of the Substance Use Disorder Services with Central City Concern, also known as CCC, in Portland, Oregon, which is one of the largest homeless service nonprofits in the country. Dr. Mendenhall is also a diplomat with the American Board of Addiction Medicine, as well as Family Medicine and Pain Management. You will also hear from Denise Kesey, who is also with CCC. Denise is a community liaison and benefit and eligibility specialist with the B.E.S.T program, which implements the SOAR model. And finally, Michael Goldstein and Vincent Nibali with the Social Security Administration's Office of Disability Policy in Baltimore, Maryland. So we will end with plenty of time for questions and answers. Now it's time to turn the mic over to Dr. Mendenhall. Dr. Mendenhall, please begin your presentation.
Pam, Bobby, and team, I appreciate everybody taking their time to participate today. And we're really honored here at Central City Concern to present to you today about our experience and also about evidence-based practices that we have instituted within our organization over the last several years. Just a quick background, and I'm going to do my best to expeditiously move through slides, and we can come back to anything that you may have questions about when we get to the question and answer period. I think Denise and the other speakers have some really important material. I'll make sure that we expeditiously move through this first part of the presentation. Central City Concern was founded in 1979, and I'm proud to report we now consist of a total of 13 federally qualified health centers and 5 community mental health center clinics, care roughly 14,000 patients on an annualized basis. We have a full continuum of services, including 1,700 housing units serving a variety of different diverse populations. 300 of these housing units are identified as permanent, and the other 1,400 are a subset of recovery housing and supportive housing with a variety of specialty programs. Central City Concern focuses, as Pam mentioned, on serving the home population of Portland, and the vast majority of our homeless patients suffer from severe pervasive mental illness, have a high degree of medical complexity, and many also suffer from co-occurring substance use disorder. Nationally recognized Housing First program, and we are proud to offer evidence-based treatment for substance use disorders within our SUDS continuum, consistent with SAMHSA and NIDA-based recommendations. From a substance use disorder continuum perspective, we offer in a variety of different facilities residential detoxification, residential services, intensive outpatient services, and a variety of different outpatient levels of care. The CC Old Town Recovery Center, and Lisa and I are speaking to you from one of the windows on the right side of the 3rd floor, in fact. So first, foundation to this talk today, I would like everybody to remember that we're talking about a chronic brain disease. Addiction is a chronic brain disease, meaning from a city perspective, it requires a holistic approach to helping people manage their illness. Addiction is just like diabetes. It's just like hypertension. It's just like hypercholesterolemia from the perspective that it takes time to treat this disease state, and that the best practices involve long-term longitudinal engagement of patients. This is a disease state that impacts the brain of our patients, and we'll be bringing up multiple times the fact that we are still in the fight against stigma and moral blaming, particularly when it comes to the mechanisms and practices that offer the best longitudinal outcomes for patients. There's sometimes an incredible amount of disparity and disagreement in judgment that comes directly from patients and individuals who identify themselves as being people in recovery, judging how others get into recovery themselves. And this is a disease state, which means that medical approaches can be effectively used for treatment, and I'm going to extend on information that you received last week in the first two presentations. The desired outcomes of managing any chronic disease are for patients to get and stay healthy and to increase the quality of life and get back to a certain degree of functionality. And when we think about patients who are potentially disabled, that's obviously a critical consideration. So I've mentioned in detail that addiction is a chronic brain disease, and science thankfully continues to improve our understanding of brain function and response to both prescription and illicit drugs and alcohol. To the next slide here. Population outcome data for substance use disorder treatment indicate that relapse is common. Outcomes are generally poor at 12 months. And this has really been brought into the spotlight, recognizing that the ongoing opioid epidemic has created a highlight on the need for a diversity of treatment options. And I mentioned briefly just a couple moments ago that cultural barriers and beliefs continue to impede access to evidence-based clinical practices. What do I mean by this? I mean that the last decade that I've been working in this field, oftentimes payers have created barriers requiring patients to fail first at traditional abstinence-only models of recovery. Abstinence-only models of recovery are models that are specifically focused on behavioral health intervention and having patients go to community self-help meetings, and do not in any way, shape, or form want to convey that Central City Concern or that me personally as a professional in this field do not support the long history of self-help and the long history of traditional models of treatment and recovery. But we have to recognize that often there are cultural barriers that exist at the level of treatment, but in terms of omission among treatment options, the failure to offer treatment options for patients that are consistent with best practices is then one of the most common forms of clinical bias that exists within the addiction treatment community. In addition to this, both patients as well as providers and health professionals, drug and alcohol counselors that have their own personal experiences of recovery may engage in very potent type of countertransference by way of judging patients who, in fact, often are more severely ill with respect to their chronic disease of addiction and are more likely to benefit from medication support of their recovery. Why important? This is important because we're talking about all patients as a goal having this opportunity to get into long-term sustained recovery. So when we really own that as clinicians, we have to acknowledge that medications are extremely useful for many patients in the setting of treating alcohol use disorders and opioid use disorders. And we have to recognize that there's a long-standing body of evidence that support both of those prior statements, and also there is excellent evidence of longitudinal management of co-occurring mood, anxiety, and psychotic disorders using SRIs, SNRIs, mood stabilizers, and neuroleptic medications. At this point, it's important to note that there's still, for many patients with co-occurring disorders, there still is stigma for patients with depression or anxiety to receive medications when they're out in their self-help groups. Oftentimes, patients don't feel comfortable talking about this. The definition and co-occurring disorders are defined as the coexistence of both a serious mental illness and a substance use disorder. I'm not going to read the quote here, but I bring us along to a very important slide, and this is a slide published from the Journal of Substance Abuse Treatment by Dr. R.E. Clark et al. And what you're seeing here in this slide was a large meta-analysis of multiple thousands of patients, identifying in the y-axis the frequency of, or rather number of relapses per 100 months of treatment, and on the x-axis length of longitudinal treatment in months. And in the green line we see the relapse per 100 months of treatment for non-opioid agonist therapy, behavioral health, so that's traditional substance treatment without medication support, comparing that to patient maintained with buprenorphine or maintained with methadone during that time. This is important to note. In the first 3 months, we're looking at a relapse rate of essentially 50% on a month-over-month basis, and it takes many months for there to be a steep decline in terms of relapses. This is important as well to note that this is month-over-month relapse, so it's an extremely common occurrence for patients, and these are not necessarily the same patients on a month-over-month basis that are relapsing, but patient relapses as evidenced by positive urine drug screen on a month-over-month basis looking longitudinally. So it's really important to note that when we're talking about patients having the greatest potential and the greatest opportunity of breaking the cycle of relapse and getting into sustained recovery, that medication support, particularly for opioid use disorders, offers the best opportunity. And how often is that not occurring? How often is that information not being presented to patients and their families? I can tell you that it's not a common occurrence, but unfortunately it is a very common occurrence throughout much of the substance use disorder treatment world in the United States today. Looks at total expenditures on a per member per month basis, and as you can see here, it's more expensive to take care of patients. So this is all costs total expenditures for patients in terms of both physical and behavioral health expense. It's more expensive to take care of patients suffering from opioid use disorders using non-opioid agonist behavioral health therapies. I also want to state that this does not mean that patients receiving buprenorphine or methadone are in this subset sample not receiving additional behavioral health support, nor am I stating that those are not important parts stated by ASAM of a comprehensive individualized treatment program, and standards are supported by SAMHSA and NIDA as well. On to the next slide here. U.S. in the addiction treatment world hoped that antagonist therapies for opioid use disorder would be as effective as they are in alcohol use disorder, and this is a subset, a modestly sized subset of patients in the LA County system, injectable antagonist therapy, and a review of best practices. And this is the percent of patients obtaining a subsequent injectable Depo-Naltrexone dose who suffer from opioid use disorder. And as we can see, the long-term engagement on a 3, 4, 5, and 6 month basis with this particular medicine is just not what we hope, and the efficacy of this agent is, I think, overstated in terms of the utility. Why is this important? This is important because that have an abstinence-only type program that they're offering, it's easy to philosophically align with the use of injectable medication, particularly injectable antagonist medication, but we just don't see the same type of long-term engagement in terms of patients with opioid use disorder. I can tell you, after doing this work for many years, that my anecdotal experience as well very much is supported by this particular graph. Now, that said, Depo-Naltrexone is extremely effective for alcohol use disorder, and very few patients have the opportunity to potentially benefit from this or the daily oral version. And in this graph, we're looking at mean heavy drinking days per month at baseline, and then patients receiving behavioral health treatment and concurrent Depo-Naltrexone, and we can see a dramatic difference. Obviously, the behavioral health treatment is having an effect based on the placebo group having a response, but there's a substantial benefit with behavioral health treatment and Depo-Naltrexone here. It's dramatic reduction in heavy drinking days for patients with severe alcohol use disorder who have identified that they have a desire to reduce or quit their drinking based on their inclusion in the treatment arm. So, Depo-Naltrexone can be an extremely effective medication with respect to this population, but oftentimes is not offered to patients. Now, this also other meta-analysis from several years ago looking at oral naltrexone reducing relapse to heavy drinking. Again, access to treatment really represents a major barrier for many patients at this time, and that's part of why we're providing this education today. Some considerations in terms of other types of medications that I'm not going to review in detail here include acamprosate and disulfiram, which are both on-label for alcohol use disorder. And then many of you are probably familiar with the off-label usage of baclofen, topiramate, and gabapentin for alcohol use disorder. There are also some new and or experimental treatments, meaning small case series abstracts that have been published looking at gabapentin and N-acetylcysteine for cannabis use disorder. We'll bring up this topic a little bit further along. There's not significant medical evidence that supports the use of medical cannabis as an exit strategy for opioid use disorder, but there's one relatively significant paper that was published recently. And I think JAMA article from 2015 really does a great job of reviewing the best evidence around the patient use of cannabis for the treatment of pain, MS-related spasticity, and wasting syndromes, all of which are quite common when we're talking about a population of patients who are applying for disability and or are identifying themselves as disabled individuals. Presenting, as you learned last week, and then hopefully in the last 5 to 10 minutes here, we're seeing an evolution, thank goodness, of treatment. Addiction is a chronic brain disease, and we have to ask ourselves, are we really treating it as one? Patients engaged in care silos between physical health delivery and mental health care delivery. Are we still viewing the concept that a treatment episode of addiction or treatment episode of substance use disorder would by itself have an end, and then the patient's on their own to maintain their recovery? And how does the continuum of care really support patients? And at Central City Concern, our wraparound services really provide us the opportunity to support people that are chronically disenfranchised, oftentimes with severe dual diagnosis. Opportunity really needs extended more generally throughout the United States. Quality is thankfully becoming a data-driven construct, and the traditional 28-day model of residential treatment followed by engagement with community self-help groups has just not clinically borne out in most populations as the most efficacious way to care for this patient population. We've reviewed evidence-based treatment, and it's really important for us to look at the big picture around words that we're using, in particular completion. Do we ever really truly complete the treatment of a chronic disease state? Warm handoffs and longitudinal care are definitely working their way into our vernacular. And as these markets evolve and our payers and purchasers continue to shift their risk, we really have to recognize that providers are becoming more and more accountable for improving outcomes across populated patients. I think it's important for all of us on this call to evaluate how are we creating value for our patients and our payer partners through our own care delivery transformation. And what must we do and or risk in terms of past and or current belief systems and culture in order to transform our care delivery. At Central City Concern, we have an incredible level of peer support. We provide peer support services delivered by individuals who have common life experiences with the people that they're serving. Our research has shown that peer support facilitates recovery and also reduces healthcare costs. And the critical component is that our peers provide the development of self-efficacy through modeling and assisting peers with ongoing recovery through a mastery of other experiences. So for us to have a rich population both in our housing continuum, in our substance use disorder treatment continuum, in our continuum of patients with severe pervasive mental illness, concept of peer, of clinical, professional support, health support, and housing support really leads to some phenomenal outcomes. use disorder perspective, it's important to acknowledge that when we're talking about chronic disease state, and in particular opioid use disordered patients, recognizing that many patients with persistent pain issues and approximately 40 to 60% of patients with persistent pain and a daily opioid that is prescribed to them regularly misuse or abuse their medication. And that does not include the percentage of patients that are self-medicating with alcohol or other substances in the context of their chronic opioid therapy. It seems most relevant to just briefly review a model for treatment phases and programming that we're using at Central City Concern. And again, this is a chronic disease model for the treatment and maintenance treatment of patients with severe opioid use disorder. We really identify stabilization as needing to be divided up into a couple different buckets. And the first bucket I've identified is in red. And those are patients that, despite access to treatment with buprenorphine services, continue to be opioid positive. That patient population will often be referred to day dispensing methadone service or referred to a higher level of care, such as residential treatment with ongoing continuation of their buprenorphine. We were opioid negative with access to buprenorphine or agonist therapies and demonstrate impairment from other substances. And those are individuals who, again, are often referred to higher level of care, recognizing that they'll continue to receive pharmacotherapeutic support from their longitudinal care team here at Central City Concern. The next box is, in our world, an orange box, but is a patient group that's in early stabilization, and those are patients that are opioid negative, are early recovery, and may in fact be episodically using substances without impairment, but are consistently opioid negative. And we've identified over a period of 3 to 6 months, and this is a consent model that many programs have utilized, that around 3 to 6 month period of time, many patients will pivot and really begin to engage in recovery and demonstrate significant self-efficacy. And progressively over time, patients are moved and maintained with medication. They're seen a little bit less frequently. They progress through our system. It's critical to consider that the clinical stage of change in each program's threshold for management of a pre-contemplative patient population is important. This is particularly important considering cannabis and or episodic alcohol use. And I think it's also important for evaluators that individuals that do insurance prior authorization or evaluators of other forms looking back at urine drug screens and identifying a specific urine drug screen as a reason to approve or not approve a claim or an episode, but rather really focusing on the overall goal, which is longitudinal chronic disease management for the patient and longitudinal engagement in treatment and recovery with a goal of functional improvement over time. Central City Concern, we take pride in really being a medical home for recovery. We have our recovery housing, our supportive housing, our long-term housing, and we interface both with local inpatients, the emergency departments. We offer our own clinical and immediate care services. Offer outpatient, intensive outpatients. Along this line as well, we have case managers that engage patients in a recovery management process. So I think independent of your own organizations and the services that you offer, it's important to recognize this really is a continuum. We're proud to be part of the continuum and have many of the components of continuum within our umbrella of services that we offer at Central City Concern. For a particular agency or entity that's on this call, I think it's important to recognize where do you fit within the longitudinal continuum of care for patients with substance use disorder, and how do you work on improving those interfaces between those subentities within your community. I'm going to hand the microphone here over to Denise in just a moment, and I have a couple more minutes here. It's important to recognize in review that addiction is a chronic relapsing brain disease. And a patient with a substance use disorder who is suffering from a co-occurring physical issue or a co-occurring mental health issue may still be extremely disabled from that physical health or that mental health issue. And I like to encourage that. I think often their belief system that medication-assisted treatment is somehow a crutch for patients, and that if they simply worked harder, that they would be better. I would argue that many of our patients here at Central City Concern, their full-time job is managing their chronic diseases, inclusive of managing their disease of addiction. I think it's important to recognize that this belief that patients need to move through a continuum of care and, quote, complete, quote, their treatment before other additional considerations will be made is not consistent with the longitudinal management concept of managing this chronic disease state. We are very supportive of patients who are still in treatment but are deemed compliant with treatment as really being an important part of patients' longitudinal care plan. Patients who are more ill have this requirement of medication, and these medications may have an impact in terms of patients' day-to-day functioning. But overall, I hope I've presented to you some compelling data in terms of what the literature shows us in terms of best practice and offering more patients the best opportunity to get into long-term sustained recovery. With that, I'm going to hand off to Denise. Here you go.
Hi there. Just give me a second to get us to the slide to move on to the next section here. So just to give a little background, you've heard about the wonderful things here at Central City Concern. B.E.S.T is a program within Central City Concern, which is the Benefits and Entitlement Specialist Team. We're a group of analysts who receive referrals from community partners, including our own resources here at CCC, for people that are looking for assistance in the event of a disability claim. We are non-attorney representatives compensated by any kind of award that our clients may get. We have about 185 community partners that are able to refer to us for services, and they'll come out of CCC, although we do get quite a few from our own programs. With that, our B.E.S.T program, we talked about quite a bit about the services that we have here. We're looking for research-based strategies, housing, healthcare services, peer services recovery, and then we come into play where there's the attainment of income, whether that be through employment or SSA benefits. Of course, we're covering the SSA benefit end of that. So that's how we fit into the programs here at CCC. What we do exactly is gathering the medical evidence, and that includes all the resources that our clients are going to see. If we have to get things from MAP programs, which also would show for us supportive compliance for the treatment due to the structure of their program. We collect evidence from all providers that they've been attending to, and we have established and maintained relationships with local treatment providers and referral sources, which is very important because we're able to collaborate quite often with the referral sources or the treating providers for our clients to get an idea of going on other than what's written in the medical evidence. You can also ask providers about cultural components that they may or may not be aware of. We have some culturally specific programs here at CCC, which is an example of when we would be doing this. We discuss the impact of substance use and misuse with our applicants. We are very clear that drug and alcohol use never helps a case. However, we can still take cases and build them when there is drug and alcohol present. As a matter of fact, the way that we choose our cases is not whether or not a client is disabled, not whether or not they are using, but whether or not we can find evidence to build them a case. We're looking for the evidence in that sense. We do echo medical sources when they suggest limiting use, and we do seek the counseling notes that are generated by our local MAP programs. It's a very important part of records and we get something other than just their dose amounts and their ways. So we're looking at the development process. We're looking at medical evidence of the symptoms in the absence of drugs and alcohol. Some examples would be suicidal ideation and depression while housed and employed to refute records that indicate secondary gain. Sometimes we have clients that will present often to local emergency rooms with suicidal ideation and or depression, and based on their homeless status or their drug addiction status are sometimes perceived to be there for secondary gain, such as housing, especially in the rainy months here. We're also looking for things such as paranoia in the absence of marijuana, which is documented by medical records, to try to differentiate between the symptoms of mental illness and the symptoms of any substance use that may be going on. We often focus on their presentation after a period of hospitalization, so at the discharge, and we also like to look for controlled supportive environments and when they're medication compliant, because how they present in that situation is really key to showing what their baseline is when drugs and alcohol are not relevant. We look to see if their presentation, for example, at this would be consistent with how they present at the clinic over a long period of time. For example, if someone is constantly presenting with suicide attempts, however, they're also intoxicated, and their mental status is similar to the way it is when they present at the clinic on a regular basis, then we can try to make a case for the fact that those symptoms are there due to the mental illness, not due to the substance. We're often faced with the challenge of finding evidence that refutes records that drug-seeking behavior. We see that sometimes, and there's an assumption that drugs and or alcohol are factors in a person's presentation, and therefore they just omit drug screen, and we don't have the opportunity then for that in that present time to show that it's not a factor. So those would be a couple of different things that we look for. We always look to include our urine analysis when citing presentations at ED admissions. We have come up with some really interesting things saying that, for example, sometimes clients with new onset of psychotic symptoms lack understanding and explain their symptoms and state that they have used drugs, but they actually have a negative drug screen. We've also encountered cases where there's a cultural component to that. It's much more acceptable to be on drugs than it is to have a severe mental illness. Sometimes drugs are referenced by clients and are in medical records. However, UAs prove that they're not on drugs at the time. We, again, include the mental status exam at the end of an admission when drugs and alcohol are or are not a factor. So we're looking for that discharge piece, whether there's drug and alcohol there, because we want to see what they're looking like in the controlled environment while medicated when there's no possibility of it being a factor. We are looking for document clean time when a client is symptomatic, and that includes periods of incarceration, admissions to the Oregon State Hospital, and other inpatient options. And this is where our established relationships with our clients really comes into play. We meet with our clients over several meetings. That way we're able to observe presentation and behaviors as well as develop a relationship where they're comfortable talking to us about periods of incarceration or long-term inpatient settings where they are symptomatic and they're being medication compliant because it is being provided to them in their setting. That's very helpful. A lot of our clients will have more records of during periods of incarceration than they do regular PCP provider records. We also make it a point to contact providers for statements regarding whether sobriety and medication compliance will help to improve the health to above the listing level. It's not all request that's honored, but we will always reach out to providers for provider statements, whether they're within CCC or not. With that. Samples of some cases that we have worked with here at CCC. There is drug and alcohol involvement, yet we are able to build cases successfully. Would be an example of a stroke where we have an active heroin user who's living in our harm reduction housing. We have harm reduction housing where there's a standing that addiction is part of the person's makeup, as is some kind of significant disability, and there's a vulnerability. So they're housed in our programs and supported very, very thoroughly to try to get them to stay engaged in treatment and also to keep them off the streets. So even if we're getting a referral from a harm reduction housing and we know at that point of referral that there's use involved, we're still able to often make a case where the use is not causing the disability. So that would be one example. Another example that we've seen here is methamphetamine use with chronic congestive heart failure that will not improve with sobriety and medication compliance. We can often get a provider statement with that. Because most of our population is homeless or potentially to be homeless, they receive preferential housing notices, which doctors sign off on, indicating that their disease could possibly end their life within 12 months, and then they have priority housing, which can also be used by us to build cases. And just the fact that sometimes, no matter what a client does, they're not going to improve. We are able to file on-the-record reviews, OTRs. An example of that would be sometimes we encounter clients that are in the queue waiting for a hearing date. However, they have a new diagnosis, and it's a terminal diagnosis. We worked a case where a client was in hearing after a state hospital referral. They had encountered some new diagnoses and were terminal. So we interrupted the hearing process with an OTR to get the person an allowance at an appropriate time. We are very fond of and often look for the use of the word baseline in medical records, because when someone's presentation in crisis is the same as their presentation at baseline, that's very helpful for us in building cases. And we often see our clients who are high-frequency ER users. The benefits of that is that they're well known in the systems, and people will reflect that in their records, and doctors will state that this appears to be their baseline. We also try to make a case for the cut and paste practice that we sometimes encounter in hospital records, whereas upon the circumstances, whether it be ER volume or severity of the reason the person is in the ER, or presentation or assumptions, no matter what it is, such as what appears to be a cut and paste process that just takes drug addiction information and just relays it to every visitation that comes to the hospital. And so we try to look for evidence to make a case that they're not currently using, that's carried over from several years prior. And so we, as a program, can administer UAs. We can also take clients for lab work so that they're medication compliant. We can take clients for psychological evaluations and cognitive evaluations to help build a case, to try to look at what we're seeing when we meet with the client that may or may not be present in their medical records. So those are the end of my case examples, and I think it's going to go head over to SSA now. Thank you.
Thank you so much, Denise and Dr. Mendenhall. We appreciate your detailing, your research, and the practical applications for assisting an individual with their disability application. Now we're going to hand it over to Vincent Nibali, who's going to begin Social Security's presentation on drug and alcohol policy. Vincent?
Good afternoon. Thank you to Pam and SAMHSA for setting this up. Vince Nibali, I'm joined here today by Michael Goldstein. We are both in the Office of Disability Policy at the Social Security Administration, And we're hoping to give you a little insight today about how drug addiction and alcoholism policy is approached or viewed in SSA, especially amid the national opioid crisis and the spread of medical marijuana. So we plan to just briefly go through SSA's drug addiction and alcoholism policy, or DAA policy as we call it, from the perspective of SSA. And we'll go through the statutory and regulatory basis of our policy, talk about SSA's explanation of our DAA policy and SSR 13-2P, go over sort of the central question, which is the materiality decision, and talk about some exceptions to the general rules. We'll also try to give you a little bit of information about how SSA adjudicators interpret DAA evidence in front of them, and hit a few specific issues related to medical marijuana and opioid use.
Hi, this is Michael here with Vince, and just thanks for having us, and thank you, Denise. That was some good practical information with respect to the evidence that you all present and we assess when determine disability for these claimants or patients. Next slide touches on the language that is in the Act. Everything that we do related to our DAA policy has to be consistent with what is on the screen right now, and that's the way of Congress and in the United States Code.
So this was from the Contract with America Advancement Act in 1996. And the relevant language is, a claimant shall not be considered disabled if drug addiction or alcoholism is a contributing factor material to the determination that the individual is disabled. Now, those are the words that Congress put in the Act. We, as SSA, had to interpret that and put that into our own regulation. And this section here is essentially talking about that materiality decision that I just mentioned. So in making this determination, we will evaluate which of your current physical and mental limitations upon which we based our current disability determination would remain if you stopped using drugs or alcohol, and then determine whether any or all of your remaining limitations would be disabling. And maybe in layman's terms, this is saying, but for a claimant's drug addiction and alcoholism would remain disabled. That's essentially the question we're looking at in our DAA materiality decision. Now, to go into more depth and explanation of this, Social Security has issued a ruling, Social Security Ruling 13-2P. The title of that is Titles 2 and 16, Evaluating Cases Involving Drug Addiction and Alcoholism. That can be easily found online if you just put SSR 13-2P into any search engine. That's, again, our explanation of how we have implemented the DAA policy, and it's going to explain when and how we're going to get to that DAA materiality decision. Now, the SSR itself also walks through a 6-step DAA evaluation process, which is really just the internal way our adjudicators answer or think about the question of materiality. If you're looking at the SSR yourself, I would recommend you not get into that 6-step evaluation process, as it's really just a way of thinking about things, and it doesn't change any of the underlying rules. This SSR is really the clearest source of our policy that's out there right now, so that would be the recommended place to go if you have any questions that aren't answered here today.
So you have the paragraph or so that comes from Congress in the United States Code. You've got a paragraph or so, a little more from the regulations, and if you want 15 pages or so of material discussing exactly what those paragraphs mean, you'll find that in this Social Security ruling that Vince was just referring to.
So I'd like to speak briefly about how SSA defines DAA. We realize that the terms drug addiction and alcoholism are a little medically outdated, but the terms that are in the Act by Congress, so those are the terms we have to use. So SSA defines DAA as substance use disorders generally, and that's to be as it's defined in the current edition of the Diagnostic and Statistical Manual of Mental Disorders. There are a couple of exceptions to that, but we'll cover those later. As I said earlier, the real crux of our question when we're looking at a case with DAA is the question of materiality. Now, only consider DAA materiality when two things are true. That is that the drug addiction or alcoholism has been established as a medically determinable impairment, or MDI. And MDI is a term of art within SSA we use to say, this has to be more than a single urine drug screen or more than someone saying that they're addicted to something. This actually has to be recognized by a medical professional. The second thing that has to be true is that we would have found the claimant to be disabled considering all of their impairments, including the drug addiction or alcoholism. Then we get to our actual question. And to answer this question of materiality, our educators apply the sequential evaluation process twice. Sequential evaluation process, if any of you are unfamiliar, is the 5-step process we go through to any disability determination, looking at whether a claimant is currently working, whether they have medically determinable impairments, whether those impairments reach the level of severity of our medical listings, and then whether that claimant can do any of their past relevant work or any other work in the national economy. So our educators, when they get to a DAA decision, are going to go through this sequential evaluation once, just looking at the entire claimant, all of their impairments, including the DAA. But find on that application that the claimant would be disabled, they will go through that evaluation process a second time to determine whether the claimant would still be disabled if he or she were not using drug or alcohol. Now, this is the crux of the whole evaluation, and it's often a difficult question to answer, particularly with the evidence that we have in file. With a lot of DAA claimants, we don't often have the clearest or most robust treatment record. But what the outcome for this question is pretty simple. If DAA is material, then we find that the claimant is not disabled. DAA is material when the claimant's only impairment is substance abuse or dependence, or the claimant's other impairment or impairments would improve to the point of non-disability in the absence of DAA. Again, that's essentially saying, but for the claimant's DAA, they would not be disabled.
Right, so the bottom line is that someone's not and can't be found disabled because of their substance abuse.
The flip side of that, of course, is when DAA is not material, the claimant is found disabled. And again, we only actually get to this question after finding that a claimant would be disabled, considering the whole person and all their impairments. But when we get to the DAA materiality question, we already know that a claimant is limited enough to be disabled. The question is just whether those limitations arise from the claimant's drug and alcohol addiction or just their other unrelated impairments. Some examples we can see here when DAA is not going to be material, of course, is when a claimant has a disabling impairment that is not at all affected by the DAA. They have physical impairments that are not affected or would not improve without DAA, and occasional grid rules direct a finding of disabled. Or, of course, DAA could have medically caused or affected the claimant's other disabling impairments, but other impairment is irreversible and could not improve to the point of non-disability.
And I think he's supplied a couple examples of those. I think there's the one with the methamphetamine use and the cardiovascular issues and the other impairment related to the heroin use. But those are examples of someone who may be found disabled when DAA is found not to be material.
So that's really the long and short of the DAA materiality question. But I mentioned before there are a couple exceptions that we want to include, or that we want to tell you about, because these can make a big difference in claimants' individual cases. So we define DAA as substance use disorders, except that we do not include caffeine and nicotine disorders. So do not count prescription medication taken as prescribed as DAA. And Now that's because, partially, AA or substance use disorders have as one part of them maladaptive use that leads to impairment or distress. And claimant is taking medication as prescribed, there is no aspect of maladaptive use.
Another point with respect to the as prescribed portion is that in another portion of the Act that we have in the slides, it does, and I'm paraphrasing here, essentially state that we will not interrupt a treatment relationship with an individual and his or her medical provider. Practically speaking, you see some interesting cases where you might think that there's overprescribing of medication, but if they're taking their medication as prescribed, that won't be considered. They're following their prescribed treatment, and that's not going to qualify as DAA.
That's exactly right. We'll touch on that a little bit later with another example, but yeah, basically, we will count as your limitations, any limitations you have from prescribed treatment. So people sometimes, whether it's cancer treatment or addiction treatment or pain treatment, have these very strong medications in their body that can cause all sorts of side effects, and we're not going to discount those just because they come from some sort of substance. Other exceptions, maybe less frequent, are children who have medical conditions resulting from their mother's use of drugs or alcohol during pregnancy. And just to sort of reinforce this point, occasional misuse of drugs or alcohol does not count as DAA. In order to have DAA, again, it must be a medically determinable impairment, or MDI. So someone having one positive urine drug screen is not going to ever get to this DAA materiality question. Other exceptions to bring up are substance-induced disorders are not considered DAA. So, for instance, a claimant who has a long history of heavy drinking and has developed chronic liver disease may not improve. That chronic liver disease may not improve if they stop drinking. That may be, permanent, irreversible damage. And we're not going to consider that as a factor of DAA. We're going to look at the independent, or now independent, underlying impairment of chronic liver disease. There are a couple exceptions to that exception: substance-induced persisting dementia and substance-induced persisting amnestic disorder. But generally speaking, you can remember that substance-induced disorders are not going to be considered as part of the drug and alcohol policy. Now to take a couple minutes talking about how SSA adjudicators approach DAA evidence and how claimants and their representatives can approach that evidence in terms of submitting it and making the strongest case they possibly can. The first to bring up is that adjudicators, or really our whole process, is focused on the underlying impairment. We're concerned with how limiting a claimant's other impairments besides DAA are. We take the whole person approach to disability evaluation. So looking at a combination of everything that limits the claimant. When we are considering the materiality of DAA, we're going through that process considering the whole person minus the DAA. Now, one thing to consider with this is that other impairments can impact a claimant's addiction and alcoholism. They increase the likelihood of starting down that path, increase access to substances, or in many cases, can change the likelihood of a claimant seeking or staying in treatment, particularly with some of the mental disorders. I believe, as Denise mentioned, or Dr. Mendenhall perhaps, there are also cultural aspects here as well that could play into whether or not a claimant is following up sufficiently with their substance abuse program. periods of abstinence, or rates from periods of abstinence, are the best evidence to show that DAA is not material in a case. That's really the gold standard and what adjudicators are pretty much always looking for. But we would point out that not all periods of abstinence are created equal evidentiarily. A period of abstinence needs to be long enough for all of the effects of substance use to abate. And it's important to recognize that sometimes periods of abstinence are not just periods of abstinence. For instance, a claimant who's in a very structured treatment setting, that additional support that they're receiving can help to mask some of their limitations in some instances. So periods of abstinence are really the best we can get, but really we would have enough evidence or enough sources of evidence or evidence from different time periods that we would be able to parse out what might be because of a substance use, what might be because of their stopping substance use, and what might be because of a supportive environment or other medical assistance they're receiving.
The reality is, and then a period of abstinence, and Denise referred to it a bit in her presentation, that provides an ideal situation for us to assess the record as a whole to see whether, the question comes back to, but for this DA, is the person still disabled? Another point is that we have some regulations on the books, the medical evidence regulations that are effective about a year now, actually a couple of years. They pretty much say, again, paraphrasing, I'm not reading right from the regs, but they say, give us all the evidence you have. So that's another point. We want everything. We want as much as you have to be able